Right, may we then move on, please, to the next item on the agenda, which is the 1718/1819 operational planning and contracting round. Matthew, will you be introducing this? Or... Okay, thank you.
So just to remind you that we brought forward the contracting round by 3 months this year, so that our ambition is to close it and complete it by the end of December, and that this year we are letting 2-year contracts rather than 1-year contracts in order to give the NHS more certainty and to be able to put in place a longer term view of the way that services need to develop. So those discussions between commissioners and providers are going on across the country as we speak. We're beginning to see some contracts landing around the country, and some of our major specialist commissioning agreements, we're getting some feedback that all the details have been agreed. It's just a question of getting the paperwork sorted out. So there's a lot of positive work going on. Clearly, in the financial situation and with the pressures on the NHS, these are not easy conversations. We're trying to get the balance between investment in prevention and out-of-hospital services right with the investment in hospital services in order to provide the best care possible. I think it's, while those are difficult conversations and professional people are doing tough jobs, our sense is that in the vast majority of places, the work that started in the STPs around thinking about the needs of a whole population and where are we going to be in 4 to 5 years' time have carried through into the contracting round. So it is a more collaborative contracting round this year than sometimes. Our regional offices and local teams, both from our teams and from NHS Improvement, are working closely all over the country, trying to steer these agreements into the best possible place. And hopefully we will get as many of those closed, and then we have an escalation process through joint regional offices with NHSI through to national directors. And for the very special ones who need extra help, Simon and Jim Mackey will personally be helping them bring their contracts to an agreement, which will be a positive experience for everybody.
Thank you very much for that characterisation. Let me invite any questions or comments to Matthew. And Paul, I don't know whether there's anything you would wish to add.
Maybe I just add 2 things, Malcolm. One of which is just to underline the importance of the earlier timeline in another respect, which is, as I'll say when I come to the financial report for this year, the big issue we've got is being ambitious about efficiency improvement and having enough credible, well worked through plans to deliver on that. And with a cycle which kind of finishes the planning in March, there isn't a hell of a lot of time to get mobilised for a year that starts in April. The intention this year is very much to do the planning so that it concludes round about now, and we have then got 3 what I'm describing as quite golden months. I'm sure they won't necessarily feel that when we're in them, but they are golden months that we haven't had in previous years to get really focused on how do I mobilise all of the things that I've planned for in a way that they start delivering in April rather than delivering kind of progressively through the year. So that's the first thing. The second thing is a kind of a new challenge for us, I think, as we go into next year, which is all about the way in which we manage risk across the system. So we've very much constructed the plans both to share the risk mitigation across whole health economies. It's the way the STPs thought about their business. And if you think just about the way in which we've constructed the risk reserve for next year, it isn't just the commissioning sector that's putting aside money for that. There is a joint ownership of it through the part of it that the commissioners put in, the 0.5% next year. There's part of the sequin earnings of providers that are being put into the reserve, and then we've got our own contribution from drawdown, carefully crafted to make sure of 2 things really, one of which is to ensure that we can get as much money as possible actually being spent next year on the priorities that we need to do, but secondly that there's joint ownership of the risks and the means of dealing with the risks, and that then allies itself, we expect, to a much more joined up way in which we manage those risks across health economies next year. So I think those are just 2 facets that are worth drawing out of the differences in process this year.
Thank you. Any other comments or questions? I mean, this was an update paper just to keep us up to speed with where things have been progressing. So, again, thank you, Matthew, for the paper and for your remarks on it. May we then turn to the next item, which is the sustainability and transformation plans.
Thank you.
Back to you.
Yes, so all 44 STPs submitted their first pass at plans and proposals in October, towards the end of October, and they cover a wide range of kind of comprehensive set of plans and thoughts aimed at delivering the 5-year forward view, aimed at improving health, improving quality and improving the productivity of the NHS, and with a particular focus everywhere on prevention and avoiding unnecessary hospital admissions, so care closer to home, and trying to rebalance services towards the kind of optimising for people in terms of where they receive their care and where they receive support. We've now had pretty nearly all of the STPs published. The last time I checked, we had 40 out of the 44 were out. We were expecting all 44 to be out by Christmas. So these are now in the public domain, and there is discussion going on across the country. You see it in local newspapers happening. And I think whilst there's a degree of noise, there's also quite a lot of engagement around it as well. The development of the proposals as they currently sit, I think, have been a very significant piece of joint effort by the various parts of the NHS and our colleagues in local government, and we're grateful to the support of the LGA right through this process in helping us build that engagement. But as we move from the proposal phase that we're in at the moment into turning these into plans to be implemented, I think it's important that the local STPs need to widen the tent of the conversation. We need to increase the level of clinical engagement. We need to increase the involvement of the public and the voluntary sector. We need to increase the involvement of elected local councillors and of our private sector partners who are helping deliver the NHS locally. Now, every SDP you go to has done degrees of that in different places. Some have had fantastic engagement with local councillors, others less so. But we need to create a standardised feeling now that this is part of a joint engagement in how we take the NHS forward over the next 4 years. And where the key priorities for local place-based decisions about the priorities for local health systems happen. So as we run into out of the end of the contracting round and into January, we would expect firstly that engagement, that widening of the engagement to be starting to happen. We would expect to see some of the proposals turning into plans, and particularly a focus on all of the STPs have kind of fall into have two parts to them. There's stuff we have to do immediately and stuff we need to put in place now in order that in 2-3 years' time you're seeing the change in the services. So we need to see those two tracks coming forward. The things that need to happen in order to improve health and improve efficiency going into next year starting, but also the work which means that we're ready for the 2 years that happen after that. There'll be some consultations that need to happen in some parts of the country where major change is going on, and we need to create the way of joint working that carries us forward beyond the writing of a document. So STBs are not statutory organisations, and we're asking them to come together and effectively choose to pool some of their decision-making rights in order to make difficult decisions and complex decisions. When you look across the local health service and you say, no individual system can solve this on their own, we need the hospital and primary care and social care and the community services to work together in order to achieve this thing. So how do the STPs create the decision-making mechanisms which allow them to jointly align a decision, which then means you can go back into your piece and make that happen, but you're doing it as part of a coherent whole. And I know that's that's something that's being much debated across the country at the moment, and our regional officers are trying to support the evolution of those structures which say accountability still lies where it lies because that's what the law says, but to do what the people need, you need to be able to pool decision making and how you share that. And I think making that work well is going to be the critical part of moving from a plan to moving to execution. So as we move into that stage, we're going to need to reset the plans with where the contracting round ends, in order that you're taking off from the place you thought you were taking off from. We've tried to make sure the STPs are involved in the contracting round as we've been going along, but that there is that step change, and then getting up to speed and moving quickly, because there's an awful lot to do in the golden 3 months that we're all looking forward to, Paul. But there's an awful lot to do next year if we're going to make the decisions that we were, and we have some decisions that we need to do as well. So we need to make some decisions around capital. We need to make some decisions about IT investment, and we're going through an exercise now internally to say the resources that are in CCGs, the resources that are in the commissioning support units, and the resources that NHS England has out in the field, how do we best align that to support the STPs? If that's going to be a key part of how we deliver change, then we need to be able to get the leaders in that area to be using the people that we have access to as part of the force that's driving this forward. So that piece of work is going on now, also about how do we get more bodies aligned around a common direction, and also to be picking up the national strategies like the cancer strategies and making sure that they are being delivered and continue to be delivered on the ground.
Thank you very much. Let me invite, I have Michelle and Joanne.
Please.
Yeah, thank you, Matthew. There has been some comment on the perceived lack of engagement with citizens, voluntary sector, local communities in the STP programme. Could you talk us through specifically how NHS England will support the STP programme to improve the engagement locally? And I think also set expectations around engagement with local communities and citizens. And second part is, can you give assurance how NHS England will meet its legal requirements through consultation and engagement with citizens through this process? Thank you.
Yes, so I think there's a couple of elements to that. One is to say that for every area where engagement with the voluntary sector has not been strong, or engagement with local councils has not been strong, there's another one where it's been fantastic, and that in part reflects where they've come from and the nature of the issues that they're dealing with and what's happened in the past. So I think to have got to where we've got to has been a pretty good show by the STPs, and I don't know, I'd be confident in saying that across the 44 STPs, there are none of them who have not got better working relationships now than they had when they started, but there is still a journey to go on. So that, but where we have to move to now is a general sense of engagement and communication, and a plan that builds on all of the strengths in an area. So being able to hear what the public feel their priorities are, but also be able to engage properly with the voluntary sector, the charity sector, who are delivering an awful lot of health and care in this country, and have a lot to offer going forward. So through our regional teams and through the SDP, our guidance to the STPs, we will be encouraging and facilitating that better dialogue and the enhancement of that dialogue, so that there's a joint sense of a way forward. That doesn't mean that every area will be unanimous on what needs to be done, because there's some tricky decisions that need to be taken, but we need to hear all the voices as we steer through that. And then, as you say, there are specific changes for which we need to properly consult, as in there is a statutory framework, and very clear that there is nothing in the STPs that takes away the obligation to consult over a major service change. What it ought to do is ensure that when we do that consultation, it's set in a broader strategic framework, so you understand why this thing, because it's part of a bigger story, rather than it just being the element on its own. But we'll be doing that, and Jane, you might want to add something to that. Jane's team are kind of gearing up to be able to provide advice and guidance on being innovative about the way in which you engage with your population, and it not just being kind of the way we've always done it.
Jane, do you want to come
Yes, that's what I thought I was just building on what Matthew said. So the patient and public engagement team have actually held quite a few events across the country with SDPs, talking to them about engagement and ways of doing it. They've developed some support tools and some guidance and help to do that. And then alongside that, we have been talking to the team centrally about how they can provide bespoke and expert advice to some of those STPs, and do that on different levels depending on what the local needs are. So there's a very clear expectation about what our 13Q statutory requirements are around consultation and engagement, but there's also the plans in place to actually provide additional bespoke support, both through the regions but also from the central team where some of the expertise lies, and we've been working on that over the last few months.
I just thought I might add, given Michelle and Jane's helpful questions and contributions, that the task force that you've asked me to chair is hopefully going to be bringing a kind of State of the Nation report to the board to allow us to reflect on lessons learnt and where to go forward, because I think this is a critical sort of area for NHS England to get right, and we're learning as we go on, so why don't we bring the learning to date? May I just ask the question that's in my head while I've got the floor?
You can try.
The question I was going to ask really is about our relationship with local government, which, as far as I'm aware, this is the first real attempt. There's been a number of attempt for NHS England to work hand in hand with local government. So I'm not surprised that we have patchy relationships in different places. What I'm keen to know, though, is what have we learnt about our relationship with local government and how we work with local government that we can bank and take forward into future strategic attempts to bring health, social care, the political framework together. I guess it's as much a question for Simon as it is for you, but it seems to me that if we can't learn from where we're at, then we're doomed to make any mistakes that we have made again.
Even more evidence next time, yes. So I think it's a really good question, and I think we are on a learning journey, and I would say, I suspect a lot of NHS managers have travelled down the same road that I have, so I understand a lot better the interrelationship between elected officials and elected members and council officials now than I did when I started this process, and how closely they work together, and that there isn't really a dialogue with one without a dialogue with the other, and I think from it's easy from an NHS point of view to view the elected council as being the board, if you like, and it really doesn't work like that. So we are learning on that journey, and some of our areas have been doing it for a long time and are a lot smarter about it than I am. But I just know from my experience, over the last 6 months of being much more closely involved in these kind of discussions, that our governance structures and local government structures are different, and we need to find a way that they can live together sensibly.
If it helps, I have it in mind to bring one or two senior local government leaders to a future meeting of the board, and we can, I think, take some of these issues together. John, before I bring you in, I've got Joanne and Moira. Please, Joanne.
Thank you. Matthew, I'd like to pick up the point you made earlier about governance.
Yeah.
So as you know, we meet with the audit chairs of clinical commissioning groups on a periodic basis, and you won't be surprised to know there's quite a lot of anxiety out there as they move into uncharted territory and governance, and are faced with a requirement to maintain their statutory accountabilities while working more collaboratively in partnership with other organisations that maybe think about things quite differently from the way they do. And I wondered, sort of, if you like, on their behalf, whether I could ask for your advice for the people who are struggling with those issues as these STPs very importantly move on.
Yeah, no, thank you, and I understand this is it's a complex question that people are wrestling with. I mean, I would say the first point that people, and I think people do appreciate, is the reason that we are doing the STPs is because we can make a better job of delivering health and social care for people by working together than we can by working in silos. And I think be they CCGs or be they acute trusts or mental health trusts or community services, if they say to themselves honestly, can I solve the challenges that we currently face by just working with my own organisation? The answer is going to be no. So then the question is, okay, so how do I make this work as part of a wider team? How do we get the service shift from one location to another, which optimises where patients are receiving their care? And from the CCG's point of view, if we want to move away from a kind of contract-bound struggle between where the money goes and into a joint view on how we're going to solve it, it requires all of the parties to, as I've been going around the country, I've been using the Bob Geldof quote from Live Aid, where he said to all of the musicians as they turned up to the recording session, you need to check your egos in at the door. There is a bit about understanding how organisations work together, and that balance between my statutory accountability, which hasn't gone away, and actually, can I fulfil this statutory accountability if I try and do it on my own? I think I probably can't. Therefore, what am I going to share and put into partnership to make joint decisions on our behalf and building that level of trust? So it's going to take some work. It's not a memo to come out from here saying everybody needs to work like this. It does need to be evolved locally to reflect the local partnerships. So they're right to worry about and ensure that they fulfil their statutory obligations because they have those statutory obligations. But their best way of doing that is to be creative and progressive about the way in which they share their accountability with partner organisations with a focus on what does best for patients.
I'm sure Matthew didn't mean this and understands it much better than I, but it still sounds incredibly top-down, that we somehow know the answers and we can help these people fix them in their locality, but actually this hasn't been done before by all of us, as it were. So I was wondering about the spread, and it's really tricky because it seems to me that local government in a sense defines itself by being different from the next area. We know that the NHS has always struggled, if it hasn't been invented here, to pick up some new way of doing things. But there has to be at some point a shift in the tone where they really do think that they are in control of their bit, as opposed to, well, we're struggling with this year, but next year they'll come along and ask us to do something else. And I don't know when that switch happens, as it were, when they'll believe that you really mean this, forever, as it were, or for as long as you're around, rather than just this year's answer.
And there's certainly in the NHS there's always a cynicism about kind of this year's initiative, but I think we're moving beyond that with the STPs. There is a tension, and which won't go away, between there are things that we as the NHS have an obligation to deliver, which you can't just decide not to do. So this is let's work out how to do this best locally around a population and reflecting the specific needs of your place, your population, and there's one NHS budget that can't be spent more than that. We have to deliver emergency services and elective services, and so on. So bringing that tension to bear and turning it into a productive relationship is the key element to this. And I guess there's a couple of things. The point I was making about where the resources are aligned. We have some STPs which are led by very senior, very experienced, very talented teams of leaders locally that we need to get out of their way, and so how do we get our resource that's there aligned properly with them in order that they can direct what needs to be done? And then we've got other areas that are evolving their ability to make big change, and what support do we need to give them to get them to that place. And part of why this is not simple is that we're trying to say there are 44 different STPs, and they are at different levels of development. They are good at different things, and part of our obligation and part of what we're trying to do is spread the best. So the question about spread, the NHS has traditionally been very poor at spread. You can find almost everything that needs to be done being done somewhere. It's kind of the mantra, but not next door. So what Ian and I have been talking about is how we help the places with the clearest thought process on things that everybody's going to end up having to do. How do we help them to accelerate and learn and publish so it becomes easy to take what was done in one place and tune it by 20% to do it in my place, rather than every time we try and do something behave as though we've invented it for ourselves. And that spread is, I think, is significant. And it's the same issue we have on the IT side as well, of how do we actually learn and not and spread best practice, and therefore improve speed and lower the cost of delivery and get it right first time more often.
You sort of just answered my comment. As you are well aware, not all egos are detachable. And in my world of clinical trials, we have an approach called adaptive design, where you try a variety of approaches, and when you check which ones are winning, you drop the ones that aren't working and redirect your resources, which I think is what you were just describing. Yes. What that suggests is that we perhaps need, as a board and as an organisation, to be analysing those STPs and having a sort of clear segregation into different categories, if you like, so that if we see one that's failing, we can buddy that one perhaps to another organisation which might have a slightly different approach but is a comparable population, rather than it being top down, trying to sort of connect sideways. Is that sort of how you see that working?
I do see it working at that level, but I also see it working at a layer beneath that. Once you dig into the STPs, there's 8 or 10 things that they're almost all proposing to do. Like every STP is made up of 6 of the same 10 things, and it's
okay.
And what we're trying to do is identify what those 10 things are, make sure that they are up and running somewhere quickly, and that they're properly evaluated, and that the best versions of them become clear. So, I mean, Ian can talk a bit about how we're trying to create that evaluation process that allows us. So, for instance, almost every STP, in fact, every STP has got a piece of it which says we have people in hospital who will be better cared for in a primary community care setting, and therefore has some sort of model of enhancement and investment in primary and community services to create what some call a hub, what the NEPC calls a medical home, primary care medical home, and so there are variations on this. What we want to do is support some of those to happen quickly and take the lessons out of that so that everybody else can go and do it, because 44 inventions is not as effective as 6 inventions copied by 38 other people. So that's. Do you want to add anything to that, Ian, about just evaluation and learning?
Just briefly, we need to scale up nationally and locally that analytical capability to be able to do the operational research and to do it in more real time, so that we can do the kind of fast failing and the wider spread. And we had a really good conversation at our executive board on that last week. So it's a really well made point.
That's very reassuring.
Right, well, thank you, Matthew, for the update and the assurance of what is an immensely complex but ultimately transformative programme of strategy, planning and operational implementation. Right.